This video is based on a clinical case scenario for menstrual irregularity. A 43-year-old woman presents with irregular and heavy periods for 6 months. She has had 2 children and a tubal sterilization 6 months ago. Her last cervical smear performed 6 months ago was normal. A blood count revealed a hemoglobin level of 11.5 grams per deciliter, which is on the borderline of a normal hemoglobin level. The following questions are posted. The first question we would like to ask is that what essential laboratory investigations do you wish to perform? Considering that this is a 43-year-old woman, we would like to know about her fasting blood sugar, her thyroid-stimulating hormone levels, and a pelvic ultrasound. It is essential to know about the status of diabetes in women, as this can influence the risk for endometrial cancer. Thyroid studies are indicating hypothyroidism is a risk factor for endometrial cancer. And a pelvic ultrasound is a sensitive and specific test that will identify abnormalities in the ovary, the uterus, and the endometrial lining. The next question we have to ask is that how will you diagnose the problem? A hysteroscopy and an endometrial biopsy is indicated as the gold standard diagnosis of endometrial lining depends on the histopathological findings. In addition, hysteroscopy can identify endometrial polyps. If the investigations fail to reveal any abnormality, what is the most likely diagnosis? The most likely diagnosis is dysfunctional uterine bleeding. What medical treatment can be offered? Progestogens can be administered orally or by a levonorgestrel intrauterine delivery system. Oral progestogens are administered cyclically over a long-term period of 12 to 21 days every month. Progestogens include dydrogesterone, norethistérone acetate, medroxyprogesterone, or drospirenone. Drospirenone is given in combination with ethinyl estradiol. The type of progestogen used must be tailored to the patient's need and to the presence of any underlying morbidities. Also, consider whether the patient can tolerate the medicine and if it is available easily locally. Progestogens are generally available easily, but they do have side effects, and so this should be kept in mind when following up patients. It is important to note that apart from dydrogesterone, all progestogens are contraindicated during pregnancy. If the histopathology report had revealed atypical endometrial hyperplasia, then what treatment advice would you offer and why? The patient needs to be advised that there is an abnormality in the endometrial tissue. This abnormality is known as atypical endometrial hyperplasia. This condition is not cancer, but it has a risk of converting into endometrial cancer over time. The risk is approximately 2% in simple hyperplasia and 10% in complex hyperplasia. The patient can choose surgery to stop the risk of developing endometrial cancer. If the patient has multiple comorbidities, which make her unsuitable for major surgery, or if it is her preference not to have surgery, we can consider giving her oral or continuous cyclical progestogen therapy over a long period. We can also prescribe a levonorgestrel releasing intrauterine system. The patient must understand that if medical treatment is administered, the patient must stay on follow-up for an extended period. If medical treatment is started in selected cases, then irregular bleeding symptoms should resolve. If they do so, then it is a favorable indication. However, if symptoms do not resolve, it may mean the presence of coexisting endometrial cancer with hyperplasia. In this case, medical management is not advised and you should proceed for surgery. This brings us to the end of the video. The script for this video is in the description box below. Please share, subscribe, like, and comment on the video. Press the bell icon to be notified about new videos. Thanks for watching.